Atypical, everyone. Hello, I'm Dr. Namirah Jamshed. I'm a graduate of Khan University and currently an associate professor in internal medicine. I've been doing geriatrics for about 13 years now. And today I am going to talk about a very important topic about atypical presentation of disease in the elderly. We will start with talking about what we call homeostenosis. The concept of homeostenosis is that we all have some form of physiological reserve, as you can see here. But when we're younger, our physiological reserve is this big and this large. As we get older, the physiological reserve actually becomes narrow, which basically means that if you had an illness here, you have all this reserve to be able to fight it. But when you're older, and if you have an illness here, you only have this much. And therefore, older people present very differently from younger people. And we'll talk about that in more detail. So the features of illness in older people include presenting atypically. And that basically means that we're used to being told that if somebody has chest pain or has a heart attack, they're going to present with chest pain. But in older people, that does not happen. In addition, their symptoms are very non-specific. They're very vague. When older people present with illness, especially if they have to be hospitalized, there's a lot more illness, morbidity, and a much higher risk of mortality that's involved. So there's a much higher risk for them. They also progress very rapidly. They can get sick very, very quickly. And because of all this, there may be health and social and financial consequences. As you can imagine, if somebody is younger and can get better very quickly, there's going to be less consequences of that. But if you're older and sicker, and even if you get out of the hospital or you get better and you continue to remain weak, that puts a lot of toll on the healthcare system and your caregivers and people around you. The other thing I teach my students is that co-pathology is very common in older people. So the first day you see an older people, especially in the hospital, and they come in with an acute illness, and you think that you have the exact diagnosis, this is what I think is wrong with them, you're most likely not 100% right. Because there's always one main thing happening, and then there's something else happening along with that. And as we talked just in the previous slide, they don't have a lot of reserve. So it takes very little illness and insult for them to actually dip down and deteriorate very quickly. Now, what should we do if we see someone who's older? Let's say they're 75 years old and they're ill. How do we plan investigation? So the investigation is based on two main things. Most important, especially in Western countries, is goals of care. And this basically means that you have an older person and they are like, if I fall sick, just, let nature take its course. If they're religious, they may say, God will take care of this. Or there may be other people and say, no matter what happens, I want you to do everything possible. So your investigation, your treatment needs to be geared towards what the goals of care are. You also need to consider the significance of a positive result. Does the positive result mean anything? For example, it's very common for older women to have bacteria in their urine without having a urinary tract infection. So if somebody comes in with fever, you check their urine only and the urine is positive, you're going to think that they have a urinary tract infection. But it could be that that's not what's causing everything. It could be something else. So the significance of a positive result is very different for older people than it is for younger people. And when we're thinking of treating disease in older people, one may consider that there may be more benefit to some older people when you use the same treatment. For example, if somebody has systolic heart failure and their ejection fraction is, say, 35%, and because of that, they can no longer walk well, they need help with dressing, they need somebody's help to go from one place to the other. Now, for that person, if you were to intervene with an intervention that can improve their heart failure ejection fraction from 35% to say 45%, that would make a huge difference to their life. On the other hand, if you have a treatment where the patient is terminally ill and is older, let's say a malignancy, the benefit of that may be less for an older person than it is for younger people. We also have to remember that there's a lot of gaps in evidence-based medicine when we talk about older people. A lot of the studies that are done in younger people, and we try to extrapolate it to the older people. And because of that, if you use the same therapies that you use for younger people, and then you use it for older people, you will have a lot more side effects. Older people can be more sensitive to the same kind of medication, and they also have physiological changes in their organs like the kidneys and the liver, which metabolize these medications differently. We also see that the response of treatment may be less immediate. So you give a treatment and you may not see the response immediately like you would in a younger person. So the physiological changes that take place as we grow older are that as we age, we have poor tolerance and a response to fluctuation in blood volume. So if the blood volume changes rapidly, it's very hard for an older person's body to compensate and to respond to it quickly. And that's because the physiological reserve is small, as we discussed in our first slide. There's also increased circulating catecholamines with blunted receptor response. Basically what this means is that an older person is like a younger person on a beta blocker. So whenever you see an older person, you're thinking, you know, oh, this person doesn't have tachycardia, even though they have lost blood. It's mainly usually because their response is blunted. It doesn't mean that they're not sick. So not having tachycardia doesn't mean that they're not sick. They also have reduced vital capacity, FEV1, and the PA2 is also decreased with age. They have reduced temperature sensation and delayed response to temperature changes. The mobility of the joints, so arthritis is very common as we get older. The blood flow to the kidneys goes down, and therefore there are some changes. That's why some medications work differently. And interestingly, they can't perceive thirst. So the safety mechanism in our body is that when we feel thirst, that means we're a little dehydrated and we need to drink water or we need to drink something. But older people can't really perceive that. And so if they can't perceive that, that means they're more prone to dehydration. Their renin and aldosterone levels are reduced. They also have delayed gastric emptying, which means that after they eat, they may feel full or the food doesn't move forward and the gastric emptying is not how it's supposed to be. And they have reduced hepatic function, which really affects how some medications are metabolized. So let's now talk about some clinical presentations that older people present with either in the clinic or in the emergency room or in the hospital. So the four main ones that we see are altered mental status. They could be confused, they could be obtunded, they could be inattentive. They can also present with dizziness. Many times they present with falls, and then they present with fever. So what is altered mental status? Altered mental status means that they are disoriented. The disorientation could be to time, place, or person. And they can have either decreased verbalization, where they're not talking much, or it can be nonsensical, which means that it doesn't make sense what they're saying. They can be somnolent, so very sleepy, without having taken anything that would make them sleepy, or it can be the opposite. They can be very hyperactive. And this occurs because as we get older, the cognitive disorder increases, and anyone who has cognitive changes or disorders actually is at a higher risk of change in mental status. So let's say you have a person who has mild dementia. If they get sick, they have a higher chance of having change in mental status than somebody who does not have cognitive dysfunction. And cognitive changes do occur with aging. The processing speed goes down, the cognitive flexibility goes down, working memory goes down. Working memory basically means that it's hard for them to plan things and to plan the day. And they also are not usually as attentive. Then there's issues about intelligence and memory and aging, and those need to be considered. One form of change in mental status is what we call delirium. Delirium is a transient cognitive and behavioral disorder. It is characterized by impairment of attention, leading to global cognitive dysfunction, increased sympathetic activity, altered psychomotor activity, disruption in sleep-wake cycle, and changes in affect. The hallmark of delirium is actually inattention. And simply put, if you're talking to an older person who has delirium, they just cannot focus and sustain attention. It could be because they're hyperactive, or it could be because they're hypoactive. So if you were to ask them to repeat world backwards or days of the week backwards, they won't be able to do it because they can't focus. And that is the hallmark of delirium. It's not necessary that every change in mental status is delirium. So you have to keep that in mind. In the US, about 10 to 22% of patients who are older and present for admission have delirium. When they are on the floor, in the general medical floor on the ward, about 10 to 30% have delirium. General surgery patients have 5 to 10% risk. The highest risk of delirium is actually after hip surgery, hip fracture, and that's about 33 to 50%. And after joint repair, it's about 20 to 40%. So it's a very high risk of delirium, and you always have to be cognizant of the fact that older people are vulnerable to this, and delirium has a lot of morbidity and mortality associated with it. So in this study, they looked at the outcomes of delirium. So if somebody has delirium, they have a 2-year higher mortality risk at 2 years. So 2 times higher mortality risk at 2 years. In the US, they have a higher risk of being admitted to a nursing home, so about 3.5 times higher. Hospital complications in patients with delirium are very high, about 4.5 times. And most importantly, delirium is associated with functional decline. So you came in, and before you got admitted, you were able to walk, talk, take care of yourself. You get admitted, you had a hip fracture, you had delirium, now you go home, and now you need help with ambulation, with getting dressed, with getting bathing done. So there's a lot of consequences that are devastating. What causes delirium? It's multifactorial. It can be infections, it could be medications, and the most common one are anticholinergics and benzodiazepines. It could be metabolic disorders. We talked about dehydration, hyponatremia or hypernatremia, hypoglycemia and hypoxia can also cause delirium. Heart failure can present as delirium. Myocardial infarction can present as delirium. CNS problems can present as delirium. And alcohol intoxication or withdrawal, both can present as delirium. Patients who don't have delirium, where their attention is not affected, usually present with change in mental status. And some of the common findings in them is usually dementia associated with psychosis, where they'll present with hallucinations and delusions. That's a form of change in mental status. They could be so severely depressed that they're psychotic. That's a change in mental status. They could have bipolar disorder and with disorientation. Very recently, we admitted a patient in the hospital with change in mental status. And the only thing we found that they had was urinary retention. A lot of older people with cognitive impairment, with dementia, or with lower back problems where their nerves are damaged, they cannot feel that they are retaining urine. And the only way they can tell us that something is wrong is by having a change in mental status, because they can't really talk and communicate with us. The other big one that we see is fecal impaction. If you have a patient with dementia, they can't explain what's going on. They will present with change in mental status. Think of it as an analogy to a child, where if they are in pain from urinary retention or impaction, they will cry. In older people, instead of crying, they have change in mental status. So with all that, you still have to differentiate whether the patient has delirium or dementia. And I hope you have a detailed talk on delirium and dementia by your neurology faculty. But simply, I'll give you a slide just to do a simple comparison. Delirium is typically of an acute onset, so less than 2 to 3 weeks. Dementia is very gradual. Delirium happens over hours to weeks, and beyond 3 weeks, we start thinking of chronic delirium. Dementia happens months to years. Delirium actually has hour-to-hour fluctuation, and dementia typically has very little variation. There's very poor attention span in delirium, as we already talked about. And in dementia, the attention span is only affected in severe dementia. The conscious level can be different in delirium. It can be hyperactive or withdrawn, but in dementia is normal. Hallucinations are common, but in dementia, they happen usually very late. Fear, agitation, aggression are also more common in delirium. Disorganized thoughts are more common in delirium, and speech is also incoherent. And the sleep-wake cycle is impaired, which means that maybe around sunset, they start getting confused. So there's a change in their sleep-wake cycle. So that was change in mental status. The next way that older people can present is with dizziness. And dizziness happens when a brain has insufficient information to be confident of where it is in space, and then it generates a sensation of dizziness. It's also because there's reduced sensory inputs and there's impairment of sensory input integration. Now, dizziness can present in different ways, so you have to take a very good history, which is what we expect our students to do really well, because a person may say they're dizzy, but they may mean different things. So a person may say they're dizzy, but they actually have vertigo, that the room is spinning around them, and that's benign positional vertigo is common, tumors are common. You can also have presyncope, like you're almost going to pass out, which can happen in people who have reduced cardiac output with vasovagal, and orthostatic hypertension, which can happen either with dehydration, with volume loss, but can also very common in older people happen with medications. Dizziness can also be from disequilibrium because of Parkinson's disease, vestibular loss, and then there's this non-specific dizziness that happens with infections. So dizziness is very common in older people, 13 to 38%, and it is not a normal part of aging. It's not normal for an older person to have dizziness, and about majority of them, 28%, are because of cardiovascular causes, 14% are because of central causes, but about 22% we just can't figure out why they have it. Unfortunately, it's associated with the increased risk of fall and fear of falling and disability. And so if somebody starts having dizziness and they're older, their function starts to decline. And when your function declines, then your reserve declines as well, and you're more prone to morbidity and mortality. So the clues to etiology would be, you can ask the patient, describe exactly what you feel. Have an open-ended question, let them tell you what's going on. And then when they've given you your story, then ask them, does the room spin? If the room spins, it's most likely vertigo. If they say that they feel lightheaded just about before they faint or are about to faint, that's usually presyncope. Does it come on when they move their head? That is usually vertigo, like benign positional vertigo. And if it comes and goes, then it can have a mixed etiology. The third non-specific symptom that older people present with is falls. A fall is an event that results in a person unintentionally coming to rest at lower level, and often a symptom of an underlying serious problem. So in an 80-year-old, if they fall, it's not usually because they tripped over something like a younger person does, or it's usually because something else was going on and it caused a fall. So it could be an infection, it could be a cardiac thing, but the fall is the presenting symptom. And if you don't think about that, then you're going to miss what actually was causing it. So multiple things can cause falls: cardiac disease, neurological disease, musculoskeletal disease. It could be from medications, which is iatrogenic, and it could be from primary gait and balance impairment. Now, if you are going to see a patient with falls, you must have them get their orthostatic blood pressures checked. The first thing you should do is ask the nurse, what are the orthostatics? Then your history, review of system, and your physical exam needs to focus on cardiovascular, neurological, and musculoskeletal organs. And if you do these 4 things, more than 90% of the time, you'll be able to figure out why the person fell. And as I mentioned before, keep in mind that it could be a marker of frailty. Fever is also another non-specific symptoms that people with, older people can present with. It depends on where you measure it, how you measure it, what time of the day you measure it, what kind of medications you are on, and if they're on any other chronic diseases. So it can be variable. But older people actually have an altered febrile response, which basically means that many of them don't have fever when they present. So just because somebody comes in and they don't have fever, that does not mean that they don't have a serious infection. In fact, if an older person comes in with fever, be very, very careful and look for an infection that may be causing it. So if they don't come with fever, that's okay, you still have to look. But if they come with fever, then there's a very, very high likelihood that something is wrong. So the new definition of fever for elderly people is a persistent elevation of body temperature of at least 1.2. So if somebody's baseline is 36, but they come in with 37.2, that is fever, okay? Or oral or rectal temperature of 37.2 and more than 37.5, okay? So keep that in mind. And keep in mind that if fever is present in an older person, it is always real. So if people have fever, it could be a poor prognosis. It is a host defense mechanism, but if you're not going to mount a fever, that means your host defense mechanism is not working. So 20 to 30% of older people with serious infection will have a blunt or absent fever response. That means that there's infection going on in there, but they don't have fever as a host defense mechanism, and so they're going to be sicker. And most of these people have bacteremia, endocarditis, pneumonia, meningitis, and abdominal infections. So these are the 5 that you should keep in mind when somebody presents and they're not mounting a fever, but there's other signs of infection. So these are the systems you could look at. In older people, if they have a fever, they're more likely to have serious bacterial or viral infection, an infectious etiology. Let's say somebody comes in, they've had a decline in functional status. Well, you know, mom used to be able to go to the toilet herself, and now she's not able to do that. And then in addition, they also have fever, then most likely there's something going on, okay? Fever of unknown origin is not very common in older people, and therefore you always need to look for the diagnosis. So 87 to 95% have a diagnosis. This is very unlike children and younger people where fever of unknown origin is more common. And 25 to 35% are from infections, 25 to 31% from connective tissue disorders, and about 12 to 23% are from malignancies. But about 95% of the time, we should be able to find the diagnosis. This is a study that showed fever of unknown origin. Initially, they didn't know what it was from, but once a workup was done, you can see that this is the younger people, this is the older people, that in older people, 70% had infections, TB was higher, you can see malignancies were higher, and this is other, as in those that you couldn't, did not come into this category. You can also see this endocarditis, also a much higher risk in elderly people with fever of unknown origin. Fatigue is another one that we see frequently, patient coming in and they're like, I'm tired all the time, I don't have a lot of energy. Please remember that just because somebody is old does not mean that it's okay to have fatigue. fatigue is not a normal part of aging. And it's very important to figure out if fatigue is acute, which means that it happened recently, or it's chronic, which is over a long period of time. There are multiple causes of fatigue, but what I wanted to point out was that 10 to 20% of people who have heart failure present with fatigue. Patients who have malignancies and they are getting treatment for cancer, 70% of them complain of fatigue. A lot of people with sleep disorders like sleep apnea have fatigue. So there's a lot of causes for fatigue, and we need to look for it and not think that, you know, you're old, or the patient thinks that, oh, I'm old, it's okay to have fatigue. It's not. So we've talked about non-specific symptoms, and we're about halfway through our talk. I wanted to talk now about specific diseases and just share with you a few ways that they will present, and they will present atypically. So if you see them, then you know what to do. The most important one, because this is going on right now, that I want to start with is COVID. So we all know that there's a COVID pandemic going on, and I'm sure even as students you are seeing cases of COVID. What I want to show you is that the hospitalization rate per 100,000 population, at least in the US, and this is the general trend all over the world, is elderly patients. So you can see that majority of the patients who are admitted in the hospital are actually older people. So it's very important for us to understand that if you're older and you have COVID, it's a much higher likelihood that you're going to be hospitalized. 8 out of 10 COVID-19 deaths that are reported in the US have been in adults 65 years and older. And that's a similar trend in the rest of the world as well. This slide shows you the difference. We're talking about symptom presentation. So these are clinical symptoms, and this is elderly patients, and this is young patients. And you can see that in older patients, about similar number of people present with cough and sputum. So 33% elderly, 40% younger people. Chest tightness, majority of older people present with difficulty breathing as compared to younger people, only 5%. Fever is common in both young and old. But look at this, fatigue. 11% present with fatigue in elderly and only 8% in younger people. Nasal congestion is similar, and sick and vomiting is also similar, okay? And if you look at the past medical history, you see that older people have hypertension, diabetes, coronary artery disease, atrial fibrillation, and liver disease, and that's how they are presenting. One more slide to show the differences, and this is a study in France, so it's not just restricted to, the previous slide was from China. If you look at symptoms, again, you see that fever is common presentation in both older people and younger people, but I'm sorry, this is the French study for older people, and this is the Chinese study that was done, and they compared it. And in the French study, you can see that they present with shortness of breath and fatigue again with COVID in the older patients. So it's very important to remember these differences. Pneumonia is a very common presentation in elderly, and we see it with COVID as well, but independent of COVID, when we didn't have COVID, even then, it's a very serious illness in older people. It comes on very slowly. They don't usually present with cough. There's not a lot of sputum production, and many times the fever response is blunted. They will present with tiredness and change in mental status. Sometimes they have nausea and vomiting. They may have some new changes on their EKG, or they actually may present with diastolic heart failure when in fact they have pneumonia. So it exacerbates other chronic conditions that the patient has. So there's one of the data that we looked at, pneumonia, the mean age of presentation is 78. Majority of them are actually from home. We have a lot of nursing homes in the US, so about 19% have present from the nursing home. And majority of patients who present with pneumonia atypically are actually dependent on their activities of daily living, which means they need help with bathing, dressing, toileting maybe. Cough, fever, and dyspnea is in 56%. But look at this. 31% of patients may not have a white count. They don't have leukocytosis, and 39% may have no fever. So patients in advanced age, premorbid functional impairment, cognitive impairment, on admission are most likely to have atypical presentation of pneumonia. So if you're more functional, the less likely that you'll present atypically. But if you're less functional, then more likely that you will present atypically. Urinary tract infection is another one where people present atypically. And a lot of this has to do with the fact that you can be cognitively impaired and again, not able to express themselves. But even in patients who are cognitively intact, the typical symptoms of urinary tract infection of pain with urination or burning with urination are not necessarily present. So most older people will present with worsening incontinence because many will already have incontinence, or it's a new incontinence that is starting to happen. Urgency and frequency may not be present. There may not be much white count in the urine and may not have nitrates. But also remember, 20 to 50% of women and about 20% of men, older men, always have bacteria in the urine. So as we talked about before, just because they have fever and you check urine or they come in with change in mental status and the urine is positive, doesn't always mean it's infection. You have to look at everything and rule out all other causes before you say, okay, I think this patient has a urinary tract infection. Heart attack or myocardial infarction can also present atypically, and the most common frequent symptom up to age 85 is chest pain. But the pain is very vague. It's not localized on the left side and radiating. It's just a vague pain. And a lot of times they will present with chest pain with heart failure. So it's a heart failure and the chest pain or feeling of vague chest pain together. And a lot of these patients with acute MI will present with confusion, change in mental status, syncope, and stroke. There's a very, very high incidence of silent MI in older people, and it gets missed about 50% of the time. So it's very important to keep that in mind when you're seeing patients with big symptoms of chest pain. When you compare older people over the age of 75 with younger people, people over the age of 65 has less typical chest pain, meaning it won't be on the left side, radiating to the neck and radiating to the arm. They have a higher incidence of heart failure, and they have a greater proportion of non-Q wave MI, okay? And elderly patients significantly delayed more than 6 hours seeking medical assistance. They also have less ST elevation, Q waves, and they have more CHF. And I think we've talked about that many times, that cardiac pathology presenting as heart failure. Heart failure is a separate entity in itself as well, where you can have heart failure without cardiac myocardial infarction. And in older people, you know, the whole classic heart failure presentation of having dyspnea on exertion may be absent. Typically they have weakness, fatigue, confusion, falls. They might black out, they have syncope, pre-syncope, they could even have cough. There's a whole entity called cardiac cachexia, where they start losing muscle mass and fat because the heart is actually getting weaker and weaker. They could have rales and crackles in the lung exam. They can have swelling in the legs or edema, but they could have leg edema from so many other things that leg edema for heart failure is not a very good sign to look at. So the better sign if somebody is in heart failure to look for is an elevation in the jugular venous pressure, or look for an S3. Having pedal edema or lower extremity edema is not a reliable presentation. Older people present with acute abdomen atypically as well. They have a poor inflammatory response, and because there's not enough inflammation in the abdomen, when you do their exam, they may not have much guarding. They may not have much spasm, and I'm going to present a case at the end. The white count may not be that high. They may not have fever, and because their bowels can be frail because of poor blood supply, much higher likelihood of having perforation. They can't communicate. Many of them have, if they have dementia, and so they present with confusion and delirium. it's important to remember that acute abdomen can be missed in older people. Biliary tract disease, interestingly, is the single most common cause of abdominal operations in the elderly. It's sometimes called biliary colic. It is replaced by only vague abdominal complaints. In gallbladder perforation, only a third of the patients had history of prior symptoms of gallstones. And common bile duct stones are found at the time of cholecystectomy in 10% of younger patients, but more than 50% of patients over the age of 70 years have common bile duct stones. So based on all that I've told you, and we have a couple more diseases to do, most of the symptoms presentation for these specific diseases are vague, and they're atypical, and they're non-specific. Acute diverticulitis in the elderly is more aggressive. There can be more inflammation and abscess, there can be more fistula, and there can be more obstruction of the colon. Peptic ulcer disease, elderly patients have a much higher risk of developing peptic ulcer disease and complications from NSAIDs. About a third of patients have no pain. You know, they teach us in medical school epigastric pain, and you know, after eating and related to that, none of that happens in older people. Most of them will have no such symptoms. Pain, if it is there, is very vague, it's not localized, it can be all over the belly, and presenting symptoms, they could just present with falls. They could have a peptic ulcer disease and they could present with syncope. They could present with fatigue because they're having anemia. So very non-specific symptoms. When you compare younger and older people, duodenal ulcer are less common in older people. Typical epigastric pain is also less common. Only 35% of older people have it, and 91% of younger people have it. Bleeding is more common. More than 50% older people have bleeding from peptic ulcer, and atypical location is more common with larger ulcers. So lots of differences there. So to end, the principles of care for older people, because they present atypically, is the most important thing is you must know what the patient's functional status is. Good functional status, more typical symptoms. Poor functional status, more likely atypical, okay? There is no such thing as you're 78 years old and therefore you're very old. No such thing. Age itself has no relevance to disease presentation or functional status. I have seen 62-year-old people who are sicker than my 96-year-olds. So age is just a number. Function is what determines what's going to happen and how much reserve the person has. So reduced functional and physiological reserve, just remember that older people will be quicker and slower to recover, quicker to get sick, but slower to recover, and they handle drugs very differently. Atypical presentation is very common. They don't have chest pain. Sepsis may present as delirium, and drug toxicity may present as falls. Older people have a lot of polypharmacy. They take a lot of medications. They go to different specialists. Everybody gives their own medicines, and then there's drug-drug interaction, and then they present atypically. And then there's a lot of geriatric syndromes. So in conclusion, the medical approach to the older, especially frail person, is different from that of the younger, requiring a much better understanding and knowledge of their illness. There's a high prevalence of non-specific and atypical illness presentation in the elderly. Even though enormous progress has been made in medical technology, the physicians must be attentive and vigilant to the illness presentation in the elderly and should play a pivotal role in avoiding delay in diagnosing and improving patient outcomes. So I hope that by the end of this talk, we're going to do a case discussion right after now. You as students can be the people who take the best history and are attentive that this is an older person and maybe presenting atypically, and you need to look at these other factors, and what is obvious may not be what's going on, okay? So let's look at a case. This is a real case that I recently took care of. This is a 96-year-old lady who had past medical history of hypertension, hyperlipidemia, and she presents with a fall and abdominal pain. She said that the pain started about a month ago with her previous hospitalization. Pain is mostly in the left upper quadrant, but it goes everywhere. Like I said, you know, abdominal pain is vague. It's worse when she lies on her left side. She does have nausea, she has fever, she has poor appetite, and she has malaise. And over the past month, she's been feeling tired all the time, does not feel like doing anything. In general, she's constipated at baseline, and she drinks prune juice to help have normal bowel movement. So very vague symptoms. Just to let you know, her previous hospitalization was for diverticulitis, and she was treated with antibiotics and then discharged home. So she was admitted in May, and then at that time with pain and fever, she was found to have diverticulitis. She was given antibiotics, and she was sent home on Augmentin. And then since the discharge, she's not been feeling better. So the morning of the admission at 4:30, she was using the restroom, and when trying to get up from the commode, her legs became weak and she fell. She had no loss of consciousness, and then her son called the ambulance and they brought her to the emergency room. In the emergency room, she was febrile. Her fever was 38.7 degrees centigrade. COVID was negative. She got IV antibiotics. This is vancomycin and piperacillin and tazomicin. This is called Zosyn here. And she got IV fluids. They gave her a 500 cc normal saline fluid. When you looked her on exam, she was alert and oriented. She could give a full history. She does not have dementia, but she appears frail and she appears uncomfortable. She had a soft systolic murmur at the left upper sternal border. Lungs were clear, and the abdominal exam was also a little bit non-specific. She had bowel sounds were normal. She was non-distended, but she had some tenderness to palpation in the left upper quadrant. Okay. So, you know, she was admitted. She was given some treatment for antibiotics. This is actually incorrect. She was given treatment for a possible diverticulitis because she was having pain and she had a history of diverticulitis. She was also found to be anemic, so she needed blood. On the second day, she started becoming restless, still very alert and oriented, and she started complaining of the pain getting worse. This is her blood work. Her sodium was dropped to 128. She was a little hypokalemic, 3.4. Chloride was 91. But you can see that she's not, her renal function remained good, creatinine 0.78. But look at this white count, 20.88. There was no fever on this day too, and she's still anemic. She got 2 units prior to this. We did a CT, and she was found to have colonic wall thickening, and it was felt that she has an infectious inflammatory colitis, and they felt that she has diverticulitis. And then, you know, we continued the treatment for diverticulitis. But she started looking worse. I went to examine her day 3, and this time again, she's alert and oriented. She has poor appetite. Her abdomen is distended now with poor bowel sounds, and we did an x-ray. And this is what it showed. So I will wait a minute. I want everybody to look at this and then think about what this could be. So hopefully you all have had a chance to think about this, but these are dilated bowel loops of the colon. These are huge, so really, really big, very, very big. So this lady had megacolon from Clostridium difficile, C. diff infection, because of multiple antibiotic treatment over the last 4 to 6 weeks. First time she came in, she got treated for COPD exacerbation or pneumonia. Then the second time she came in, she got treated for diverticulitis. And now the third time she comes in with C. diff. But she never had diarrhea. And so previously she wasn't tested until we saw the white count and the signs of dehydration and this x-ray. It was evident that she actually had C. diff colitis with megacolon. She was sent to the ICU. She was admitted. And then subsequently, we discussed with her the goals of care, which is very important here. And I hope it's important even in Pakistan. She initially did not want anything done. And then she realized that she was not ready to leave her family and let nature take its course. So she decided for surgery. And within 4 hours of going to the ICU, she had surgery done. They had to do a total colectomy, the whole removal of the colon. And then she was kept in the ICU for another day. She actually did really well, got better. She got a ileostomy, and then she was sent to the floor, got lots of physical therapy and rehab, and then went to a rehab facility to get stronger. So this was an atypical presentation of a patient who initially presented with fall, but ended up having an infection of C. diff with megacolon and eventually and requiring surgery. So that's it for the presentation. I would like to thank all of you for giving me the opportunity to talk about this important topic. I hope that you all learned something. I would like to thank Dr. Irfan Suleiman for giving me this opportunity to present this talk. And I would really like to thank Jinnah Sindh Medical University to providing this opportunity to do this educational activity. If you all have any questions, please ask Dr. Suleiman for my contact information. I'd be happy to answer any questions for you. I'm very proud of having my cousin graduated from Jinnah Sindh Medical University, who is now a physician in Australia. And there's some wonderful colleagues and friends that I know here from your medical school. Good luck in whatever you decide to do. And again, I hope you learned something. Thank you very much.